All right, we are very privileged next to hear from Dr. Jeffery Braithwaite, Professor Jeffery Braithwaite. He's a leading health services and systems researcher with an international reputation for his work investigating and contributing to systems improvement. He's the president of the International Society for Quality in Healthcare and is an expert and advisor to the WHO, the OECD, and many research groups around the world. His research examines the changing nature of health systems. His key expertise is in quality of care, patient safety, systems improvement, and implementation science. Research he's designed and studies he's led have reconceptualized healthcare, applying complexity science and cultural theories to a wide range of healthcare problems. He's received over 57 different national and international awards for his teaching and research. And I unblurred my background because I'm actually sitting in the office next to him because I'm visiting Sydney and hosting this from there. And I'm sitting in Enrico Cuera's office, which is next to Jeffery Braithwaite's. And this was on the desk, so I promptly ordered it, and I will be reading this soon, but this is the latest book, it looks like, that he has co-edited with authors on implementation science, the key concepts. So I hope he doesn't mind me advertising that because I think it looks really important. With that, we will turn the time over to Jeffery.
Thank you. It's a pleasure being here, and it's great to contribute to mobilizing computable biomedical knowledge. This is kind of a very exciting time for learning health systems, biomedical knowledge, and the fact that we can mobilize and get evidence into practice, which is a great passion of mine, is fantastic. So I'm Jeffery Braithwaite, and I'll talk a little bit about where I am and what I do as a way of framing what I'm going to say. But my tenor is not to talk so much about MCBK, but to really roll our sleeves up and figure out where's the health system heading, perhaps to 2030, and then where does MCBK fit in? So I'm from the Australian Institute of Health Innovation. It's a big group of researchers who do health systems research. I like to say we don't have a laboratory. We don't have a wet lab. Our laboratory are the health systems of the world. And we try and figure out how we can make healthcare work better. So our logo is Heal, Learn, Discover. And I'm going to talk a bit about the MCBK logo and how that overlaps with what we do. So, and we're here in Sydney, Australia. And if you haven't been, you need to get down and you need to come down under and come and give a talk at our research institute and have a chat. So the institute itself, we have 4 directors each who run a research center. And as you can see, there's a lot of words that map to MCBK. We've got myself, I run a research institute essentially interested in health reform and change. Joanna Westbrook does medication safety, aged care research. She's a professor of health innovation, health informatics. Enrico Cuera also runs a center in health informatics, and Henry Cutler is a health economist. And we've got a whole lot of other centers, for example, to the right of us, which are funded by our equivalent to the MRC in the UK or the NIH in the US. So we've got a whole lot of centers all surrounding the whole idea of improving healthcare using data, getting more evidence into practice. And so before we begin, I started to think, what are we trying to do with mobilizing computable biological knowledge? What are we trying to do with MCBK? So you'll know that MCBK has a manifesto, and the knowledge aspect of the manifesto makes some very startling statements that knowledge has the potential to improve healthcare for all, that every decision affecting health should be informed by that available knowledge, and that everyone on the planet, all 7.8 billion of us, at least in principle, should have access to this knowledge. These are lofty goals, fantastic goals to have. In the manifesto, there's a whole lot of other words about it's not sufficient to have static knowledge in books or pictures or is stuck in PubMed without it being being able to be accessed in a more agile, amenable way. We've got to go to scale on that. This has the potential to improve care for patients, decisions that clinicians make, the evidence that has been assembled, and I'm going to talk about that, is available. So this is a fantastic thing to do. There's also a vision for in the manifesto to support action to improve human health, that treating knowledge and learning as a public good, so it's widely available, ensuring knowledge reflects and practice, I say practice as well as knowledge, reflects the best current evidence and science. And achieving this is really the goal of MCBK. And there's also some mechanisms, and I'll talk about this a bit further. There's some mechanisms that have been specified by the MCBK proponents, early adopters, which are really useful. So we need a handle, I think, to understand that and operationalize it, we need a handle on other trends in the health system. So let's have a look. And this is my talk now. So there's a problem with all of that I encounter every day as a researcher. And the problem's something like this. Here's my my attempt at the problem in one slide. It takes on average 17 years for only 14% of everything that's made available as scientific and medical knowledge to enter practice. So there's 28 million papers in PubMed, and that's a very poor report card on all those studies locked in PubMed. About 60% of care is in line with evidence or consensus-based guidelines, in line with the evidence that's in PubMed or Medline, or the guidelines that clinicians themselves say should be followed to deliver care to patients. 30% of care is estimated to be waste of some kind, test results that never get seen, procedures that are futile, underservicing, overservicing, administrative burden. And 10% of patients are harmed when receiving care. Mostly it's small-scale harm that doesn't really, certainly doesn't lead to mortality, but some does. But, these numbers, all three of these numbers, these 60, 30, 10 numbers, are something for us to be concerned about and are a stimulus for MCBK. And so is the top bullet point, of course, too. So we published a paper on this a couple of years ago, pointing out that if we did well on just those three numbers, the 60, 30, 10, we'd have a better health system. If we had higher quality care, the 60%, less waste, 30%, and less harm, the 10%, we wouldn't need to do much else. We'd be presiding over much better healthcare and much better health systems. So we have to solve that 60, 30, 10 equation. So what have people done to solve the numbers that I just gave, as well as the numbers where there's a lot of papers in PubMed that aren't seeing the light of day or being actioned or find their way into practice? Well, people have come up with a pipeline approach and said, if we do good basic research and discovery research and do some RCTs, and then translate that into health technology assessment and do health services research, which I do, knowledge management, which is also part of what I do, but also it's one of the words in MCBK. And we will preside over a better health system. We will deliver better care to patients. This is one representation of this. There's many of these. If you just go to Google Images, you'll see many of these. But there's problems with this because it assumes that things are logically going to happen in order in a time series of events, and that we'll instantly get better healthcare at the end of the pipeline. Because what we know about pipeline type models, linear models, is they are idealization. So there's always blockages and barriers and fractures in a pipeline that mean that at the end, we don't get success always. Sometimes we do. We get failure. And so I think that's the space that MCBK is trying to address. That's the space MCBK is trying to operate in, but it's the solution, my take on the solution that MCBK is trying to solve. Okay, so I've made it more clear, I hope, in my head, and I hope in yours. So the next thing I want to say is there's a further problem. And that is healthcare is extremely complex. It's a complex adaptive system. Now, the pipeline models that I just explained suggest solutions are linear. If I do X, Y, Z, A, B, and C, I will get F or G or H or whatever it is that I'm seeking, a very logical model. The solutions to healthcare, though, are not linear because the health system is complex. It's incredibly complex. Now, let me give some examples because there's complex systems everywhere. The extended family is a complex system. Your networked computer system that you're working on now is a complex system. Parliaments and governments. Here's the German parliament. The human brain. Not all systems are complex, of course. That's my joke. I'll pass over that. And it's rarely simple to solve any health system problem, therefore, because of this complexity, not just a pandemic. Because health system problems are typically complex problems, not linear problems. They are intricate, multifaceted, multidimensional problems. So we've got to ask ourselves, how does healthcare actually work in the delivery system on the front lines if we're going to address some of these problems through MCBK? So what I'm going to say is encapsulated in a white paper we wrote a couple of years ago, and it's a free download. You can go to our website and download it. Lots of people use this. It sort of encapsulates how healthcare is a complex adaptive system and applies complexity science to it. I'm just going to summarize what it says. So we know the properties of complexity. There's lots of agents interacting. It self-organizes. A complex adaptive system self-organizes. It's a collectivity. There's lots of networks. There's rules that are generated by a network, by a complex adaptive system. There's a property called emergence, which is kind of another way of saying things happen that we don't necessarily envisage or predict. Things emerge, they happen. There's levels of uncertainty. The system's adaptive, but not necessarily the way we want it to be adaptive. Healthcare is so complex, it sort of moves along without necessarily us saying this is exactly what we would like. It's dynamical. It's bottom up as much as it's top down. We like to think of healthcare as top down. I'm going to discuss that shortly, but it's actually bottom up as well. It's always in transition. Health systems are always in transition to something else. It's governed by feedback. It's path dependent, which is another way of saying if you're not in tune with this complexity lens view of the health system, it's path dependent, which means that where you came from matters and describes where you are now and influences where you're heading. So in essence, therefore, there's populations of agents and their artifacts, their things, their computers, their stethoscopes, their test results interacting dynamically with lots of emergent rules and governance mechanisms and bottom-up networks of clinicians delivering care and bottom-up networks of patients receiving care. So that's complexity. Now, we've done a lot of research on this, looking at the delivery system and how it delivers care. So here's a study we did for the last 10 years, a longitudinal study of a translational cancer research network in Sydney, Australia. So the dots are people, and the lines between them are collaborations between those people. And this is the network in 2012, and then this is the network. This is a network trying to get more oncology evidence, trying to get more clinical evidence to do with cancer care into practice. Researchers like me working with oncologists to deliver more care. 2012, that was the network. 2013, that's the network. 2015, that's the network. By 2017, that's the network. And 2021, that's the network. So we now, across 10 years, really are influencing the front lines of care. We are trying to get more evidence into practice through these networks, through this research project of enjoining people who do research and understand evidence with research, with practitioners, policymakers, and patient groups and policymakers, trying to improve the care we deliver to that population of patients that has some form of cancer. Now, that's mobilizing computable biomedical knowledge, but it's in quite a static way. We're doing it through people. We're not doing it augmented so much by technology. We're creating a collaboration to mobilize knowledge. Here's another example. I do the implementation science, me and my team do the implementation science for Australian genomics. That's a very large project right across Australia to try and get more genomics knowledge into practice. So here's before 2016, when we first measured the network. This is medical scientists, geneticists, medical specialists, researchers. And here's the network by 2018. And this is ongoing. We're measuring this again soon. So in summary, the system we're trying to MCBK is, if I can use the term as a verb, in summary, the key lessons are healthcare is complex. It's a complex adaptive system. It's adaptive without us necessarily saying we have to adapt to X. We're at Y and we have to adapt to X. Behaviors are emergent. Bottom-up clinical behavior produces localized rules that help determine how we deliver care. Linear models will only get you so far, and we have to factor all this in to what we're trying to do. So the next bit I want to talk about is, well, what are we aiming for? If MCBK is a solution to some of these problems to improve the delivery system and get evidence into practice much more frequently, robustly, often, and intelligently into the hands of people who need to make decisions, clinicians and patients, but also policymakers and managers and leaders, then what are we aiming MCBK at? What are we trying to achieve in terms of a better health system? So let me have a look at this with you. And this is work I've been doing for the last about 10 years. So I'm series editor with colleagues, but I'm the overarching series editor on a series of international health reform books. These are big books, compendiums of people writing about their health system. The first book was about 30 health systems, and it was about quality and safety in those 30 health systems. Second book said, what's improvement look like when you're actually making improvement in your health system, whether it's policy-led improvement or on-the-ground clinical improvement at the coalface. And that involved 60 countries, 60 health systems. The third book, which is the one I'm going to talk about, asked, well, what about the future of healthcare in your health system? And we involved around 150 countries. And that's, there's only 190 countries, depending on how you count a country. There's only 190 countries in the world. So we got most of the world. And we asked people, well, what's the future? If you think about what you're doing in your health system now, if you're a researcher or a policymaker, what's the future look like? And so this is available on Amazon if you want a big book, but I'm going to summarize it now. There's also a summary paper anyway in International Journal for Quality in Healthcare, which I published a couple of years back. So lessons can be taken from this global outlook on the future about what healthcare may look like, or we hope or aim for it to look like, and where does MCBK fit into creating this health system of the future with your particular country in mind. So these are the countries we got. All the coloured countries were involved. Some of the grey ones weren't. We couldn't get to every country in time for the deadline for this book. So we didn't get to every country, but we got to most of the world. It's a statement about most of the world and what it's doing. And I'm going to summarise now what we learned from that, what we all collectively learned, 150 authors in 150 countries. Well, there's 5 trends running through health systems to the future. Everyone's trying to work on how to create a sustainable health system. Everyone's working on Genomics. How do we unravel genomics and get precision medicine? How do we exploit emerging technologies? Telemedicine, hospital in the home, all the sort of new diagnostic technologies, new drugs. How do we cope with changing global demographics? The fact is, populations are aging. They're more demanding. They want different kinds of care that suit them rather than the clinician. And how do we deal with new models of care, new ways of delivering care, new propositions for care during the pandemic, telemedicine, for example? So these are happening now in any case, regardless of whether MCBK happens in the way that we hope it will. I mean, MCBK is going to happen in some form or lots of forms, but regardless of whatever else we do, these seem to be trends running through every health system and are happening. More in high-income countries, less so in lower-income countries because genomics, for example, is very expensive and new technology, but these are happening now. And there were 9 solutions proposed in this book that we extracted from the book that people talked about. And we're going to try and have more integrated care so patients don't fall through the cracks. We're going to have more efficiency, better financing in economics and insurance, and doing better with the money we're given, whether it's privately funded or taxpayer funded or co-pays or whatever. We're trying to figure out how to empower the patient and create patient-based care. We're also trying to make sure that there's universal health coverage in every country. Some countries have that. Other countries are striving towards that and don't have it. We're also proposing as a solution lots of technology and information technology, electronic medical records, bedside testing, all the stuff that we've come to want and are halfway over the fence in trying to produce. We're also dealing with aging populations, trying to do preventative, not just acute health. We shouldn't just think about MCBK, for example, as an acute care application. We're also trying to have a standardized, wise, accredited, policy smart health system and using those as levers to improve things. And we're trying to create a workforce of the future. So our work points to this being summarized on a slide. I've summarized this on a slide to you. The road to 2030, with those 9 things in mind, with those 5 trends running through every health system, is trying to get more integrated, value for money, patient-based health systems with universal coverage, with IT literate, IT-enabled systems, with health literate, healthy-orientated populations, focused on preventative, not just acute care, with high-quality, safe, standard-based care, and with a workforce that's well-trained and fit for purpose and understands genomics and technology, for example. So we're moving from the system as we know it, the one that I've critiqued, on the left-hand side, fragmented, siloed, volume-based, more provider-orientated than patient-orientated, with barriers to access and affordability, legacy-based static systems, unhealthy populations to some extent, with not very good literacy, focus on acute care, entrenched levels of poor quality, uneven workforce training and development and knowledge, to a one that's more on the right-hand side, cohesive, value-based, person-centered, access without financial hardship to care, machine learning and AI enabled, that's MCBK stuff, well-being, healthy aging and health aware, a shift to primary care and health promoting and preventative care, less harmful, more effective services, less 10 in the 60-30-10 equation, and a fit-for-purpose, highly trained and sustainable workforce. And that's, I think, what we're heading for. So just a slight interreigning period. I've got some questions you might want to formulate back to me at the end of this. Of course, you can ask me any question in the Q&A. And I'm going to start to end now the talk, but 3 questions that might be useful for us is, how might MCBK benefit from an understanding of the 5 trends and 9 priorities? Because I think that's the game plan. It is based on our work, my work and lots of other people across the world, on how the health system might be shaping up and what it might look like if we get it right. Now, the question for you is, what challenges does the 5+9 model pose to you if you're an IT specialist and researcher and systems designer, change agent, a visionary for health systems like I'm trying to be, and an architect for the future? And are there any other trends or themes that you think are important for us to factor in beyond the 5+9? We think that's a pretty comprehensive model for what the health system might look like in 2030. And we're figuring out how MCBK fits in, but you might have other things, other important factors beyond the 5+9. So I'm in the final stages of this talk, and then we'll go to Q&A. So what are the implications for MCBK? I've talked about this a little on the way along, but let's have a think about that. So MCBK can act as an enabler of and a pathway to the future, which I've represented by the 5+9 model, but you might have your own model of 2030 and what it might look like if we get it right. I think ours is pretty comprehensive, but you might have other views. Many of my group across the world would see the vision of the 5+9 model as central to understanding the system we're trying to create to 2030. And we're figuring out there's a natural match to the MCBK manifesto that I started with and the health system of 2030. So the MCBK manifesto is to take advantage of the capabilities of computable knowledge while continuing to establish practices that validate knowledge, preserve it, and ensure it can be trusted. In other words, we're trying to rebuild the A380, the jumbo, while we're in it. We've got to run the current health system and rebuild it as we go along. And that's the essence of my work to 2030, and I think it's what MCBK is trying to do. How do we get to this version of 2030? This snapshot slide of what we're aiming for, what we hope for the health system of 2030. How do we get there? So there's many ideas. Obviously, MCBK, in my view, and in the view of this conference, is going to be central to creating that system of the future. I just add some others. Lots of people see transforming the health system through a model. WHO has a model for managing change and innovation. I'm not going to speak to these. I'm leaving them for you in the slides. There's lots of other models of change and improvement. I think it's good if MCBK people understand some of these change models, as well as my game plan for what 2030 might aim for and what we're hoping for. There's lots of models like that of how do we do the change and transformation in the health system to produce the care that we all would be proud to deliver and want to receive as we interface with as a patient in the health system. Lots of models. There's lots more. I'm just going to put them up for completeness, but you can sort out the ones you prefer for your bit of changing the health system for the future and making it better. My take on it, so let me finish with 8 suggestions. I know 8's too many for people to hold in their head, but the slides are available. Let me propose 8 things to you in concluding. One is, I think we spend a lot of time inside our box, wherever our box is in the health system, or researchers or policymakers, trying to think linearly, inevitably thinking, if we do A, we'll get B. And then we step outside of the box and realize it's a complex adaptive system. So one message for all of us is to get out of our box, embrace the complexity, and lead our bit of the needed MCBK transformation to create the health system of 2030 that I'm passionate about. Another one is we need an implementation science-based plan for doing what MCBK is going to produce for us. So have an implementation plan. Here's ours from 2014. We published it. Lots of people use it. There's lots of plans for how to do a science-based implementation strategy for improving the health system. The thing is, I think everybody has to do 2 things. They have to know their job and do it and improve things. This is the we're fixing the plane while flying metaphor, and I've written a paper on this recently. So if we think about the health system, often we think about it as an organization chart. You know, there's a CEO and, you know, the clinicians are on the front lines at the bottom. If we think about it, that's doing your job and you've got a job description, okay, and you're going to execute your job faithfully. But actually, healthcare looks like not the organization chart, but the right-hand side diagram. It's full of inconsistencies and uncertainties and complex behaviors. And in amongst all of that, enmeshed behavior, you've got to improve things. So you've got two jobs, not just one job. Do your job and improve things. My fourth suggestion is understand deeply that our problems and solutions are not linear. That's the case I made in the first part of this talk. So we can't think of MCBK as a linear thing that's just going to get adopted. It will be effortful. It will be a journey, not a destination. There will be many missteps along the pathway to improvement. My fifth point is focus on what's important. I like to think there's just three numbers, and if we address those, if we got better quality care, less waste, less harm, we'd have a better health system instantly. Hard to do though, but that's my equation to be solved. Next point is, I think we have to do continuous evaluation and implementation. This is a journey, not a destination. Here's my model for doing this. Seventh point is we've got to be able to go to scale. We have to be able to get MCBK to scale, and here's our model for going to scale. You can read about this. We've written this in a paper. And then finally, we're going to look at what a high-performing hospital, if we're going to apply MCBK stuff to hospitals, we have to look at what a high-performing hospital actually looks like, just like we have to look at and have a target of what the health system to 2030 might look like with our aim to use MCBK to get there. Here's my model for a high-performing hospital. We did this as a systematic review. You can read about that too. So I'm happy for discussion, comments, questions, and observations. A couple of things. Here's a hi to the MCBK crowd from some of our people in Sydney, Australia. Here's some acknowledgements. I've drawn on lots of our work in my institute. Some of the people who I list there, I'd like to acknowledge because I draw on their work within our institute and elsewhere. Here's some recently published books. I'm currently publishing books with a whole lot of colleagues, faster probably than some people can read, but we're creating a store of information. And of course, you would say, and I would say, we need to get that to be mobilized knowledge, not just stuck in books. Here's some forthcoming books in case you're interested in some things that I'm interested in, and we are fellow travelers and curious people together. And finally, this is how you want to contact me if any of this has interested you deeply and you want to continue the journey with me. So that's all I need to say. Thank you very much for listening. I hope you've enjoyed this, and let's go to Q&A. Thank you.
Well, Jeffrey, I couldn't take pictures of your screens fast enough. So I hope the slides are available for all of us because there's so much there to go back and revisit. Thank you so much. I want to start with just a kind of a comment about the vision for 2030. And I thought, wouldn't it be great if we could actually achieve that by 2030? Do you think we're on the pathway?
So, thank you, Wendy, great question. So every health system that we included in that long project, that 10-year project, is some way towards some aspects of the health system to 2030. What we did was just look across the world at what people were doing, encapsulate that in a model, synthesize it into that model, and then said, well, how realistic is it that we could make those gains? So it's a bit of an idealization. Any projection to the future is going to be a best guess, an approximation, a conceptualization. Will we do that? Well, some countries do better than others at some aspects of those, exploiting those 5 trends and reaching those 9 priority goal areas. For example, if you think about the Scandinavian countries, they're really good at having information on their population at the population level through lots of registries they have of the status of their population and the care. Other countries don't have that, more individualized countries like the US, for example. So different countries are firing at different levels in different ways towards that model. But what we've done is pulled it all together and said, well, here is an idealized model. If we approximated that, the characteristics described in the model, in a health system, it would be a health system we'd be proud of. And then, you know, my stuff, Wendy, I've tossed in that 60-30-10. Here's 3 targets, 3 measurable targets for us to meet. And if we did both of those, then we would have a better health system. The main point to your question, which is a fantastic question, Wendy, is I'm trying to figure out, and I think people on this call are trying to figure out, how does MCBK mobilize, Chuck calls it a movement, mobilize to underpin and help create that better healthcare by 2030? That's the real next equation to solve.
Yeah, excellent. So that leads into, there are 3 questions from the audience that are very similar. And so I'm going to take the prerogative of the facilitator and kind of lump them together. And they're all about the human who's making the decision. And so, and that's where, you know, MCBK is really focusing. How do you take that knowledge and get it into the hands, you know, and make it actionable so that, that people can do the right thing, you know, every time. And we're making it easier for them to do that. And that, you know, that we all know that humans are overwhelmed and cognitively limited in even the specialists. And that our goal, we don't have to solve this complex system, but we have to be better than the unaided mind. And I think of Chuck's, you know, theorem of informatics, biomedical informatics, of the human plus the computer is greater than the human. So thoughts about that and how that fits into the bigger picture.
Fantastic question. Thank you to the audience for, and thank you for synthesizing that across several questions or points from the audience. So my sense of this is, you know, the human brain, apparently, we're told by, you know, the neurobiologists, the human brain is the most complex thing in the universe. There are more connections at the synapses in the brain than there are atoms in the universe. It's some sort of crazy claim like that. So it has huge capacities, but it's flawed and has limitations, the human brain. And one of the flaws and limitations, and this comes out in your work, Chuck's work, Enrico Coira's work, Joanna Westbrook's work, in fact, lots of my favorite informaticians and people, is that the information that's available in a health system through electronic medical records, patient histories, genomics, whatever, is too much for any one person to cope with. Even what looks like a fairly trivial decision between a clinician and a patient has so much wrapped around it and within it. So that, in essence, is the MCBK problem. How do we get the right information at the right time, in the right place, to the right people when they need it, that's up to date? And we can't just leave it in books that I write or edit and 28 million papers in PubMed. So that's the absolute essence of the problem. We can boil that down to 2 things. One, how do we get that information on a handheld or in a timely way to the person making that decision? And then 2, how do we then keep that up to date across time? That's what MCBK is all about. Now, there will be many ways we do that. I mean, the immediate thing people think about if you're an informatician is, well, that's an app. Can we have an app? You know, I run my life on my app, on my apps on my iPhone. But this level of knowledge, this level of sheer data complexity, it's not going to be easy to do that. So it's relatively easy to specify what we need to do. It's very much MCBK's mission to try and enable that in different ways, in different forms, depending on the decision maker. But, you know, people talk about AI being able to do this and talk about artificial intelligence. I don't think it's artificial intelligence. I think it's augmented intelligence. The human still has to make a decision, augmented by the information that can be put in their decision-making process at their fingertips to help make that decision. And I often think about this. The best application of this is a clinician in front of a patient right there and then, having to assemble and understand all that information, sift through it, and then help with co-design of the patient's care, make that decision in conjunction with the patient.
Thank you. All right, we're not going to be able to get to all the questions, so I have one final question, and it's a challenge to you. So thank you to the person who posed this. Do you think there could be a way, analogous to making clinical guidelines computable, to make the insights in your books computable in some kind of an expert system?
Yeah, that's absolutely brilliant question. It's that's why it was asked, of course, to challenge me.
Yes.
It is a real problem, isn't it? I mean, amongst the most static of things are books. And what do I keep doing? Writing books with co-authors and then, putting them on Amazon for somebody like you, hopefully, Wendy, to order. You said you were going to order it. The most recent one. Well, I'm going to put that back to the MCBK people. I'm just a sort of usurper. I'm just sort of part of the crowd, but not actually an MCBK informatician myself. I'm a health systems guy. I'm going to put that back to the questioner. How can you and I work together to make that stuck in words, in books, in papers, in PubMed, in static databases, in studies that nobody reads, even in New England Journal of Medicine, to create that and then get it to go to scale? That's the $64 million question. Happy to work with MCBK people, you, Chuck, Philip, and the MCBK leaders, because that's at the heart of the problem.
It's a hard question. I think it's a great one, and I'm going to throw something out there and see what you think.
Yeah,
that's the idea of collective impact, and we all know there's thousands of people working towards this 2030 vision. Millions around the world. But how do we measure it? And the collective impact idea has several elements where you can all be working towards the same thing, and none of you can get there because it's so complex. But if there's a shared way to measure, and there's shared communication and things, then we can start to track that and be more synergistic. And I wonder if the 60-30-10, could that be something that is measurable across different silos that then you could start to track progress?
Yep, I agree. The 60-30-10 is certainly measurable because it's three numbers. And the nine priorities on the road to 2030 are also measurable, or you can create metrics for integrated care, universal health coverage, how much of the care is patient-based, really, rather than lip service being paid to that idea. So that we can mobilize measurability to see how we're tracking, moving to a better health system by 2030.
Yeah. All right. Well, thank you. And hopefully we'll be able to continue that discussion. Really appreciate your insight, Jeffrey, and your leadership in this space and spending time with us.
And I appreciate yours too. And Chuck and Philip and the MCBK people. Thank you very much for the invitation.
Thank you.